Okay, hi everyone. This is Lola. I'm the coordinator of the Harvard and Beth Israel Deaconess Medical Center site for the New England Mental Health Technology Transfer Center. Please feel free to introduce yourself in the chat box if you'd like. And now I'm just going to go over some housekeeping items before we begin. Next slide. Participant microphones will be muted at entry. If you have questions during the event, use the chat. This session is being recorded and it will be emailed out to all participants once it becomes available. If you have questions after this session, please email newengland@mhttcnetwork.org. At the end of this month, MHTTC will send you a certificate of completion that you can then submit to your particular board for continuing education credit. Please contact ifisher@c4innovates.com for more information on CEs after the event. Next slide, please. This slide summarizes some of our MHTTC acknowledgements. Next slide, please. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, and lastly, consistent with our actions, policies, and products. And with that, I'll hand it over to Dr. Shirley Yen for some introductions.
Great. Thank you, Lola. And actually, I have to pause my share because, oops. I could just introduce Dr. Crowler as my best friend from graduate school and how we got each other through, but that's not sufficient. So Dr. Martha Crowler serves as chair of the Department of Community Medicine and Population Health and Associate Dean for Research and Health Policy for the University of Alabama College of Community Health Sciences. She's a professor in the college's Department of Community Medicine and Population Health and Family Internal and Rural Medicine. She provides behavioral health care to patients at University Medical Center. Dr. Crowler earned a bachelor's degree in psychology from the University of California, Berkeley. She received a master's degree in public health with a focus on chronic disease epidemiology from Yale University, and she received her PhD in clinical psychology from Duke University. Dr. Crowler completed clinical internship and was a postdoctoral fellow at the Palo Alto VA. Prior to joining the college, Dr. Crowler held faculty positions in UA's Department of Psychology and the College of Arts and Sciences, where she also directed the clinical psychology program. She holds appointments as a faculty scholar at the Alabama Research Institute on Aging and as a scientist at the Center for Healthy Aging in the Department of Medicine Division of Gerontology and Geriatric Medicine at the University of Alabama at Birmingham. And prior to everyone getting on, we were reminiscing that we had also gotten each other through graduate school by bringing our laptops to the local Chinese restaurant in Durham, North Carolina, working on internship applications and our dissertation proposal. So thank you so much, Martha, for presenting today. I am going to share your slides. Oops. Okay, let me go back to that and go back one. Oops. Great. I will hand it off to you now.
Great. And just to let you all know, there are 5 people who have entered the waiting room.
Okay.
All right. Thank you, Shirley, Dr. Yin, for the opportunity to present today. I'm really excited and very passionate about this topic. I will try to leave room at the end for questions, but if you have questions in real time, please feel free to put them in the chat box, and I will try to be a good steward and check the chat box. And I'm hoping Dr. Shirley will let me know if there's a message or question there. So the title of my talk today is Older Black Americans and Mental Health. Again, my name is Martha, and I'm the one doing the primary presenting, but one of my former graduate students, who is now a psychologist at the Durham VA, helped me develop the first version of the slides. I wanted to make sure every time I give this talk, I give her credit for her help. All right. So in terms of learning objectives, there are 4 that I hope to cover today. To recognize the importance of understanding the historical context of the lives of older Black Americans, I think really to work with older Black Americans clinically, it's important to understand their historical context within our country. And I will also explain, once we get past our learning objectives, why I'm using the term Black Americans and not African Americans. And I hope that that will be very relevant and make sense to you all. A second aim or objective is to recognize the importance of eliciting the older Black American's perspective for his or her mental and physical health problems. And then the third objective is to elicit socio-cultural and spiritual beliefs that could influence older Black Americans' healthcare choices and access to care. And finally, I hope to enhance your knowledge regarding assessment, diagnosis, and treatment of major mental health disorders when working with older Black Americans. Next slide, please. Thank you. So the reason why I'm using older Black Americans instead of older African Americans, which by the way was my initial title, older Black Americans cover a diverse group. And given that many of you are in the Northeast, this is particularly important. So under the rubric of older Black Americans, it includes Caribbean Blacks, and there's a huge Caribbean Black population, particularly those from Jamaica or Haiti, in the metropolitan areas in the Northeast and the Southeast. And then there are also Blacks of African descent. So when we just say African American, we really are covering the Blacks from African descent. Although when we say that, we think we're also covering those from the Caribbean, but technically the term to do that is older Black American. So for some of you, that may be a new way to think about kind of the right terminology, but I want to kind of start there and then apologize in advance that you may hear me go back and forth between older Black Americans and older African Americans. I'm trying to switch to just saying older Black Americans, but by default, sometimes I do say older African Americans. Next slide, please. All right, so the current group or cohort of older Black Americans was told stories during childhood about slavery, the Civil War, and the Reconstruction period. And those were times in American history that are highlighted by racial violence and social upheaval. Next slide, please. Thank you. The childhood and young adulthood of the current group of older adults occurred during the Great Migration. So that was a period in our country when we had African Americans moving from the South, primarily to the North and sometimes to the Midwest. And then they would eventually come out West. There's this great book, by the way, it's called The Warmth of Other Suns. And it is a fantastic book that traces the migratory patterns of African Americans. It's really incredibly well done. It's by Isabel Wilkerson. So if you have any interest in this area, that would be a great book to get. But it's really important to understand that Blacks were moving not because they just wanted to move, but they were moving for greater financial opportunity and to hopefully alleviate some of the racial hardship they were experiencing in the Deep South. Next slide. Older Black Americans fought in or supported war efforts of World War II. During World War II, African Americans fought for peace abroad and returned home to face inequality, segregation in education, housing, employment, and health. Now, I was curious about this. I will share this with you because I looked it up. I wanted to know how many older Black Americans actually served in World War II. And as of November 2023, there were 119,000 still alive. So, okay, I am a geeky academic. I just wanted to know. So the group of older African Americans or older Blacks who served in World War II is declining. However, that next cohort of older African Americans still heard those stories. They probably had relatives who participated in World War II. Does that make sense? So that history is still very alive for the current group of older African Americans, older Blacks. Next slide, please. Now, so what's really important is today's older Black Americans, most of them were middle-aged during the 60s, and we don't often think about that, right? We think about these young people protesting. Not the young people didn't, but just to put that in context. And now we have kind of multiple cohorts of older Blacks. So you have some who were middle-aged, some who were younger, just given the aging of our population. But the 1960s, as I'm sure many of you are aware just from what you know about history, was an era for the civil rights movement that was considered the most profound and revolutionary period in American or Black American history since emancipation. So that's really important to kind of keep in mind as we then again kind of move on to how do we work with them more effectively. Next slide, please. Thank you. During significant periods in Black American history, we had the NAACP was really, really important. And that stands for the National Association of the Advancement of Colored People. And it was formed in churches and played a large role in social and political activities. So what's interesting now, we still have a lot of our group of older Black Americans who still attend church on a regular basis, particularly in places like the South. But however, trends across the country are showing that Black Americans aren't as active in their churches. So one thing I want to make note of here, we still tend to think that's our knee-jerk place to go if we want to do recruitment, if you're working on like a clinical grant or a grant of any type. If you want to kind of reach that population, we go to churches first. But I want to point out that what we want to do is partner with community agencies, including churches, but not just exclusively churches, to reach older Black Americans and kind of understand who they are and work with them more. Next slide, please. So this slide, I will explain the reason why I put this, and I hope you will agree with my selection of this slide. I put this slide together to talk about all the current events that have happened since right before 2020. And then that will give you a context for, I hope, the rest of my talk. So we kind of talked about the historical context for older Blacks. And now I want to talk about what's been happening in our country now and how both of those things absolutely impact how we need to work with this group. So we had the Black Lives Matter movement and protests that happened before 2020, but not a whole lot before 2020. So that kind of started some of our cascading current events. We had economic insecurity, which was a really big deal. The political divide, which is still very much alive in our country. I'm not going to ask any of you what side of the divide you're on, but we know that there's a divide, and that's impacting all of us in some way. We had gun violence in our country, in schools, in other places. Now we have, elementary schools, middle schools, high schools, they're doing drills, just gun safety drills, those kinds of things. Or, what to do if you have an active shooter. That's what I'm looking for, active shooter drills. So that's really important. We know abortion rights are an issue. I live in Alabama. Now they're talking about fertility as, things related to fertility and how to manage all of those things. We had our Capitol riots, or the insurrection, as some people term it. That was a big part of our country, and we're still talking about the fallout from that. And this question of who is an ally, that started with the Black Lives Matter movement. Were you an ally? Did you support that movement? If you did, what did you say? How did you say it? If you didn't, what did you say and how did you say it? That kind of extended to other diverse groups, talking about like the LGBTQIA+, that group, and how do you think about, again, being an ally or not? So those questions are really important. And then face masks. Face masks, as we know, they were a really, really big deal around 2020. Not just did you have one, were you wearing it correctly if you were wearing it? And then we had vaccine hesitancy, and we had health disparities. Health disparities were absolutely occurring amongst the Black American population, and definitely in urban, but also in rural communities. So that was a really big deal. So this group that we're talking about today, or that I'm talking about today, older Black Americans, were absolutely impacted by COVID. We saw an increase in deaths in that population, particularly, again, in highly concentrated areas for that population. And we also saw that group as a whole, there's some data that shows that they actually were not vaccine hesitant, and they were willing to wear their face mask. If you're interested in that, I can send you, I will send them to Dr. Yin, and she can follow up with any interested and send you the references for that. It's really interesting data. Some of it is coming out of Mississippi, but then some other places as well. But we still saw some health disparities with that group. So to me, just reading all this list to you all, and I apologize, I read through it relatively quickly to hopefully get to the very end of my talk and open it up for questions. But this context, it makes me tired just to read all the things that have happened pretty much in the last 4 to 5 years. So now we're trying to work with the population who has experienced turbulent times in our country before. So in that regard, they may be hardier than some of us who are here, but that doesn't mean it didn't impact them. But at least they had a context to work with it on. But it may help you to think about how do you work with them, just thinking about all these current events. Next slide, please. All right. So just in terms, very quickly, some of the health issues with this population, they constitute 36% of low-income older adults. That's a really, really big deal. And they're more likely to receive only minimum Social Security benefits. They're less likely to receive pension income. They're more reliant on SSI. Excuse me. The chronic disease rate is twice as high as compared to Caucasians, and they're more likely to perceive themselves as in poor health. Next slide, please. Their hypertension rates are higher when compared to Caucasians. Their stroke rate is higher. The rate of obesity is higher. Kidney failure and diabetes rates are pretty high. And they are more likely to be completely incapacitated, and their less access to healthcare is, unfortunately, is pretty high, and they're more likely to use emergency rooms as an entrance to hospitalization. So all of what I went over relatively quickly is supported by the literature. Again, if you want some articles, I can send you those. But it just kind of says this is a population that has some pretty high, that have some strong financial needs, as well as some strong health-related needs that we have to address. Next slide, please. Okay, this is really important. Now, this is true actually of the African American and the Asian American population per the literature. They're more likely to use home remedies, lay consultations, and folk medicine. So it's really important if you're working with older Blacks, older African Americans, to ask them, so what do you take at home to address your issues, whatever that may be, because they're likely to, take garlic for hypertension is a very common one within African Americans, but to be mindful and ask those questions is really important. They have higher death rates for lung, prostate, and other cancers than other ethnic groups, and they're least likely to enter nursing homes. So that's not a preferred choice for this population. However, once they are admitted to a nursing home, if admitted, they are the least likely to be discharged. So what that really means when you talk to people who work in nursing home settings and kind of understand this pattern more, that because of the reluctance for many older African Americans or Black Americans to go into nursing homes, they don't typically go until they're really, really sick. And it's probably because a family member cannot provide the level of care that they need at that point. So they're sicker when they go in, and they typically pass away there. The downside of that, it creates this pattern that if you go in a nursing home, you just die. Instead of thinking, well, maybe you go for a while until you're more stable and then you can return home. So that's really important if you're working with older adults and you're kind of dealing with someone who may have mental health issues, but they also have some physical health issues, to kind of think about that, like what level of care is really important, and to kind of work with them to find the appropriate level of care before it's really late. That may require, we'll talk about this a little bit later, but talking to that person as well as family members who participate in their care. Older Black Americans are also more affected by social stressors than financial strain. So, and that's really, really important. I have worked with a number of geriatricians, and they talk about this. It's really quite fascinating. So it's almost like the financial strains are something that they have grown accustomed to. It's the social stressors. Those could be family stressors. Those could be stressors that are happening at their churches or in their neighborhoods that will really, really impact this population and subsequently impacts their mental and physical health care. So one example I will use, I worked with a geriatrician for years, and he had a patient who had been managing his chronic conditions well, and then they weren't being managed. And luckily, he just asked him, tell me a little bit more about why you think your health is changing. And he went on to talk about all his stressors, and they were all related to some changes in his church. So the geriatrician understood where his lane was, and talking about his church changes was not his lane, but he was able to say, this seems to be a true source of stress and is preventing you, as the patient went on to talk about, he wasn't taking his medications the same way. He was just kind of, it was throwing him off. He was out of his routine and pattern. So he just talked about the importance of returning to his routine and pattern, and that helped the patient to kind of get back on the right track. So the physician didn't try to help him solve his church issues. He just kind of pointed out that there was connection between these social stressors and his health. And I point that out for all of us. Sometimes we stay in our lane too much, and we don't necessarily help our patients just see connections that could really help them. Again, he didn't try to take over that role and become like his pastor or try to mediate any of that. He just pointed out the connection, and that was enough for the patient to go home and address it on his own. Next slide, please. Thank you. The role of the church is really important. And again, let's see, it has a greater sense of satisfaction in the lives of many older Blacks or older African Americans. It's a place where church historically has been a place for a ton of activity, including social changes, political rallies were there, social justice issues were brought up in the church. The church was the centerpiece of Black or African American life. That is changing some. The pattern is changing across the country. You're still more likely to see that in the South, but definitely not in all parts of the country. So it's important to think about other places that Black Americans are using for community gatherings, but that is still one for now anyway to think of, just not exclusively. However, a sense of religion and spirituality is still a big part of Black or African American life. Next slide, please. All right, thank you. So a majority of our older Black or African Americans were raised in the church. And that provided an opportunity to address all kinds of things. You could address health disparities. You could talk to people about, their kids and how a healthy diet is important across the life course, those types of things. You can combine spirituality with healthy living, more preventive messages than alcohol and abstinence. So you could talk about gluttony, smoking, physical activity. So one example I will use here, just because I brought up things across generations, I do a lot of work with grandparents who raise their grandchildren. And all I have to say to a grandparent, if you make this change, this will positively impact your grandchildren, they're willing to do it. When I talk to them just about their own health, it doesn't seem to matter as much. They listen very politely, but it's almost like they're stuck and don't necessarily want to make any behavioral changes to then impact positively their physical or mental health. But if I say, if you start eating healthier, specifically, if you make smoothies and you can put spinach in them and the kids don't know, and then they start doing that for their grandchildren that they're raising and also for themselves. I've had a retired nurse, she comes, I did a support group for years with this population, and she would talk to them about, like, when you cook your greens, when your water turns green, turn it off, because that means you're now cooking out some of your nutrients, those types of things. So they seem really, really simple, but just kind of walking through this population in particular, probably all the patients we work with, but giving them concrete examples. Too often we say, don't do this, but we don't replace it with what people should do. Particularly, again, what I have found in my own clinical work, but also when talking with other practitioners in my read of the literature, is we're very good at the don't do, but not so good at kind of helping people. And they're not going to ask us, well, what should I do instead? So if we're ready, kind of have, something packaged, that can be really helpful. So when I talk a lot about the combination between mental, the body, we only have one body, and our mental health and our physical health work in combination. So I will talk to people about going walking, running, swimming, whatever works for them. But often it's walking, and we talk about going to malls. I don't know if you all know this, malls open at least 2 hours early before the store opens, so people can walk inside the mall. Sometimes I live in the deep South, it's hot. So in the summer, no one wants to be outside because it's too hot. In the winter, it's too cold. Well, go inside the mall, and they have benches throughout the mall, which are great for middle-aged and older adults. They can kind of they can sit down for a minute if they need to rest, and then walk the rest of the mall. So it's really lovely. So thinking through, again, not just the don't do this, but also encouraging them to do this. And it's been really nice for me to see that I can get people to, engage in more chair exercises, to walk in malls, and how that actually addresses some of their issues with anxiety or depression, right? So sometimes we think we have to come at it head on. This population doesn't necessarily want to hear you talk all the time about them being depressed or anxious, but you can talk about some other things that will absolutely positively impact their depression and anxiety. Just some thoughts about working with this population. Next slide. Okay, so civil rights cohort, they're more likely to be between 55 and 70 years. Religion was woven in the movement, they were that age. And what about the next cohort? So we have to think about the relationship between age and religious participation. And again, as I've mentioned before, right now we have older adults who are more likely to go to church than younger cohorts. So you can still reach some of our older population there, but not necessarily, maybe not their children or grandchildren there. Just a thought. Next slide, please. Okay. So given all what I mentioned before about the historical context of life for many older Blacks or African Americans, it really is an accomplishment for them to reach old age, given the disproportionate physical, social, and psychological harm that occurred. I'll talk some about racism more specifically in just a second, but it's really important. So this cohort, I think, we don't often celebrate them for that. So we focus a lot on all that's wrong. Their finances may not be great, their health may not look as great compared to other populations, but they're still here. So that means that they're resilient and they figured out some things. So I have, and I encourage you to try to do the same if you're working with this population, highlight that. Just say, gosh, it's amazing that you're still here. What do you think has contributed to that? It's always nice to me for people to hear that and then kind of think through themselves, what do they think has contributed to their health and well-being as well as it is, and then we can kind of move on from there. So kind of using their data in every step of the process to help with making positive changes for them. Next slide. All right, so this is just a quick profile that I hope will kind of bring to life some of the things I've already talked about, but this is another way to meet people where they are. So we have Joe, an 85-year-old Black American. He was diagnosed with hypertension 15 years ago. He exhibits dramatic fluctuations with his blood pressure due to non-compliance with prescribed treatment regimens. His physician is unaware of the effects of using the word hypertension versus high blood pressure among Black American elders. So using the term high blood pressure will more likely lead to better adherence. So that's the part what I meant about meeting people where they are. So sometimes we're using terms, and they're very appropriate. They're the terms we learn. We can say depression, we can say anxiety, and they mean something to all of us, but that doesn't necessarily mean that they mean something to the population that we're working with. So if we're working with older adults, I try to talk about symptoms. So kind of go through symptoms of depression or symptoms of anxiety and talk from the symptoms as opposed to talking from the label. And I found the older populations I work with, people are very responsive to that. And when I talk to others who work with this population clinically, they have found the same. Again, the labels they don't really work as well, but the symptoms help. And we administer assessment questionnaires, and that helps us to we can look at the data, and then we can see the best way to approach people. Okay, next slide, please. All right, so I'm just going to make this one brief. This is just amazing to me. In 2019, not having enough food was reported 3 times more frequently by Black persons and 2 times more frequently by Hispanic persons than by white persons. That's a big deal, not having enough to eat. While older adults overall typically have extremely modest retirement savings, minority households have even fewer financial resources to rely on. So money's a big thing. So if we're working with them, we have to figure out, how to incorporate strategies to help lower their depression, anxiety, or whatever else is going on than necessarily sending them to a pharmacy to buy medication. Does that make sense? So we have to kind of be a little bit more creative in our approaches. Or when I mention, I don't really talk to them about going to the gym. That's not where we start anyway. We talk about maybe going for a walk in your neighborhood if you feel safe to do that, or you can go to the mall or other things. So I try to start with assuming that income may be an issue, and then we can work our way from there. Next slide, please. So given the relationship between poverty and health, clinicians should, again, develop strategies that work better for this population than necessarily thinking about medications as a first line. So as a psychologist, I don't prescribe, but I don't necessarily, but if I'm partnering with one of my psychiatry colleagues, then we talk about other things we may do first, or how we can think about that medication piece differently. And again, I try to come up with ideas that will help them cope with their mental health issues that are free or they can do at a reduced cost. And understanding the differences, this is really important to me, between urban and rural poverty is huge. So I grew up in San Francisco, but now I live in a state that has a lot of rural poverty. Not that California doesn't have pockets of rurality. I just wasn't exposed to them as much there, but here I'm exposed to them a lot. But transportation, healthcare, and other resources are really big deals. So when we think about things, we have to be mindful of transportation. So I have a lovely older woman. I saw her yesterday. It takes her an hour to get to me because she has to take there's a senior bus available. They pick her up an hour to an hour and a half early. And she always wants to be my first person. So yesterday our appointment was at 8 and they got her there early. They usually don't get her there early. So she was there at 7:10. Our clinics don't open until 8. So she's standing outside. Luckily, the weather was nice, breezy, but nice, but you get the point. Like, transportation is a real issue. So I am trying to move her. She used to work. She did everything early, liked to be on time. So I'm trying to get her to move to a little bit later appointment just to help her manage her transportation issues. That's just kind of one example of how it's really, really important to think through some of those things. Next slide. Okay. Sorry. And this is my only slide about rural older adults. I think most of you are in urban areas, but now that I live in a community or a state that has a huge rural population, I've fallen in love with the rural areas. So 25% of the 65-year and older population live in rural communities. Often rural elders are isolated. Now, I want to put a pin in that. If you paid attention to the media lately and read a lot of research focused on older adults, loneliness is becoming a huge issue for this population in urban and in rural settings. So it's something to be mindful of and pay attention to, is older adults being isolated. So in rural communities, that's happening because younger adults are moving to more urban settings for employment often. But in other people are moving around. So we're having this kind of issue of loneliness for many of our older Blacks in our country right now. And along with, in rural areas, the out-migration of the young people, there's actually been an in-migration of retired people. So it's really interesting. In some rural communities, you just see a decline in population, a lot of loneliness, a lot of older adults not being able to get their needs met because there aren't young people who help them. But in other communities where you have retired people moving back from more urban settings, who are moving back with higher level of education, with great skill sets, that's been interesting. So not all rural communities look the same anymore. So I encourage you, if you're interested in looking at rural older Blacks or working in rural communities, to pay attention to what surrounds that rural community. Is that one of those places that are getting some of the retirees from the West and the North? Those places are starting to look different because those people are bringing more money back to those communities. Again, higher levels of education, they're volunteering more. So those rural communities are interesting and different than some of those that are a little bit more isolated. Next slide. Okay, so I really want to stress the importance of this, building collaborative ties. It's really important, if you want to work effectively with older Blacks, that you strongly consider not just the person, but you consider their family. So typically older adults, they come with often adult children or grandchildren, someone else who's participating in their care. It's almost the same way we think about working with children. We don't think about working with children without the context of them having guardians. So with many older adults, many Black older adults, family is such an important piece of their lives that typically there is someone who is helping with their decision making as it pertains to their mental and physical health. And to kind of understand if there is that person, for the person you're working with, is really, really important. You may want to involve them in their care, of course, with the primary older adults' permission. Involving communities. Communities are incredibly important. And often we just in terms of resources, we don't think about what's around us or what's around that older person we want to work with. So engaging communities can be really helpful. So the why here, I think this is a program throughout the country, but I'm not positive, but it's called Silver Sneakers, which I love Silver Sneakers. They do a really nice job at offering services at their Ys at a reduced rate. So that's something that could be really helpful for some of the people you may be working with. There are other community agencies. There are some churches that have some really cool programming for middle-aged and older adults. In my community, it's often for middle-aged and older Black Americans. It's been really important for me. So to be a part of that has been really fun. Many churches have health ministries and kind of asking to speak at one of those. So I'm giving a talk in 2 weeks at a church, an African-American church, because they wanted to understand more about mental health and aging. So it's really a great opportunity. I give that talk for them, then they follow back up with me. Does that make sense? If they have health issues, I can try to partner them with healthcare providers. It's a really nice partnership. So I want to encourage all of you not to miss understanding what's going on in local communities. And then as clinical, and then us as clinical clinicians and researchers, some of us are both. We do clinical research, but partnering can be incredibly helpful. So there may be some really cool research studies that maybe some of your patients, if they're older African Americans, could participate in. Just don't miss those opportunities. Researchers do some cool stuff, and so do clinicians, but sometimes we aren't talking to each other. So just kind of working to build those ties with local universities or others in your area could be really great. Next slide. Thank you. We're talking about older Blacks, older African Americans, then we need to talk about bereavement for a minute, particularly because of COVID. So overall, there's a deficit. There's not enough in the literature that's talking about bereavement in Black American populations in comparison to other populations. 70% of older adults experience a loss within 2.5, within a 2.5 year period. The rate is higher among older Blacks, and it's really important to keep that in mind. So I mentioned earlier that there's a lot of loneliness in this group as a lot of their family members move away, typically for educational or financial opportunities. So they're losing, you have younger people moving away, and then they're losing their friend group to bereavement. During COVID, a lot of them lost friends or siblings to COVID or other health things related to COVID. So that's something to pay attention to. And many African Americans have a higher risk of experiencing untimely loss of a loved one. So if we go back to the Black Lives Matter movement, that kind of, when I talked about the current events, that's a really big deal. So a lot of those older Blacks know someone, know a family member where a younger person has passed away. So they're just kind of higher rates of loss. Does that make sense? Okay. Stoicism may also be a key role in Black Americans. So you ask them how they're doing. Fine. I'm fine. So they're less likely to report that they're having a really hard time with bereavement. So just asking more questions can really be helpful than saying are you really sad because of that loss? But overall, how are you feeling? And just kind of taking a deeper dive if you know that they've had a loss could be really helpful. Next slide, please. So examples of Blacks grieving somewhat differently includes racism, might have been how like their loved one passed away. So how they think about grief and loss is different. And it also may be uncomfortable for them to talk about it. And I don't know the race and ethnicity of most of you joining, but I really want to say this, and there's a ton of literature that supports this. You don't have to be the same race or gender of the people you're working with. What you have to be is compassionate. Does that make sense? And that makes the biggest difference, and allowing people to tell you their story. So I'm a big believer in that. We're all different and we come from different places. So I started this talk by talking about the history of African Americans and Black in this country. And that's really, really important. But even if you don't know that, every one of us has our own story. So allow people to tell you who they are is the best way to work with them, regardless of you looking like them or not. So like histories of poverty, racism, discrimination, and oppression represent additional stressors for older Blacks. Again, those are just things to be mindful of. And if people feel like you're there to listen to them, they'll tell you their story. And then you can figure out how to use that data to kind of help them through their current bereavement period or other things that may come up in your work with them. Next slide, please. So some ways that has helped Black Americans cope with bereavement has been religion and spirituality. This is one of those places where you don't have to share their religious beliefs and values. You just have to understand their religious beliefs and values. I worked with a lot of older African American or Black women, and they will say, which fascinates me, and I've done some research with this population, it kept coming up in my data, and then I added a qualitative component to try to figure out what was going on there. But they talked about is church was a place for them to provide support, but not necessarily receive it. But what I realized, they go there to be helpful, but that also is helpful for them. They just weren't kind of tracking that piece of it. That's why they kept going. That's why they kept helping. So it did help them. So there's something about just the community, their religious community could be really helpful. But they often see it as a place where they go to receive help. And they talked about praying, their relationship with God was their way of receiving help for themselves. So they give help by going to a setting, to church. They receive help in their more private places in their prayer meditation, which is really, really important to be mindful, but just being respectful of their religious and spiritual beliefs. Again, you don't have to share them, just being respectful of theirs can be really helpful. Social support is another way that helps many older Blacks, and they're just a resilient population. Again, if you live to be old, if you live to be an old Black person, you are typically pretty resilient. Just allowing them to tell you a little bit about their story could be helpful. Next slide. Okay, cognitive impairment, we know, is an issue that comes up as people age. And cognitive status is generally associated with activities or daily living activities like using a phone, taking public transportation, managing your finances. So this is a really big deal to be mindful of. This goes back to when I mentioned many older adults often now are talking about feeling lonely. So the question is, do they have people who can help them with those activities as they age? It doesn't mean that they're all impaired, but it sure is nice if you can if you're working with them, to see if you can assess their support network. Does that make sense? And kind of make sure that there's someone who can help and support them if they start to have any of these issues. Something that's really, really important with cognitive status, we know, is also physical health. So we want to assess physical health to see how they're doing, and if we need to kind of maybe partner with a physician to put something in place that may help them cognitively. Those things do often work together. Doing assessments, cognitive status assessments can be incredibly helpful. One thing that's really difficult when you use those assessments, they typically are education biased. So depending on the older Black person you're dealing with, the level of education may be low. So they won't score as well on the formal cognitive assessments, just something to pay attention to. But that doesn't mean that they're kind of like, particularly their problem solving skills may be really good practically, but they may score poorly. When you ask them other questions, they may not do as well. So for example, I love this the first time I did some work with older rural Blacks. And we asked, one of the questions asked, it's a cognitive impairment questionnaire, but it is trying to assess problem solving. And it asked, what would you do with a frozen turkey? Almost to a participant, they were like, why would I have a frozen turkey? You just go in the yard and get a turkey, right? So their problem solving skills was just fine. They had to figure out like how to answer it, because technically they didn't answer the question. But they knew what to do. If you ask about medications, it's typically one of those questions, like, how do you get your prescriptions filled? Those types of things. It's typically, they may say, I don't. What that really means, often when you ask more questions, they'll have someone who goes to the pharmacy for them to pick up their medications. Does that make sense? So I think sometimes our cognitive assessments, we have to really look at the questions, be mindful to level of education, And also just be mindful, like, are they really relevant as written for the population we're working with? Next slide. Okay. So systematic and institutional racism among older Blacks, particularly in the Deep South, is a really big deal. It does impact how they respond cognitively and the diagnosis that we choose. Biased examiners and systematically biased education could also have great impacts. So Jennifer Manley, I know she's in New York. I'm sorry, I'm blanking on the university at the moment. She's done a lot of work with cognitive assessment and older Blacks and the importance of really paying attention to that educational bias. Again, it's Jennifer Manley, M-A-N-L-Y. There are others. She just is coming to mind at the moment. She's done some really nice work in that area. Around 27% of Black people live below the poverty levels in the US, and they might be living in areas with limited health care. So those things really do impact how people score on some of our more standardized assessments. Again, just being mindful of that could be really important. Next slide. Okay. So cognitive impairment also may be attributed to lifestyle factors, health, and SES. So just thinking through those things could be really, really important. For example, if someone has high blood pressure, we know that may impact a lot of their other health issues. And how do we think through that? They have diabetes. All of the chronic conditions can, over time, impact impairment. So thinking about that, that's why the relationship between mental and physical health is really, really important with this population, and it's often been overlooked. So meeting people where they are, you may not send them to the gym, but that doesn't mean you can't suggest other things that would help. Next slide. There's a lot of literature that documents that there's a lack of cultural sensitivity when addressing health disparities, particularly in our testing instruments. So sometimes it looks like one thing, but it could be another. It's the terminologies that's used. How do we think about these things? People may be functioning pretty well, but it doesn't look like that because they score so poorly on our tests. I think I've said that now 5 times in different ways because it's really, really important to pay attention to. Next slide. Thank you. I can go to the next slide. I've talked about that. Thanks. All right. I want to make sure I touch on depression and anxiety. So there's a wide range in rates of reported depression symptoms among older Blacks. It depends on, as we know, that there's not a standardized instrument that everyone across the country is using when they assess depression or anxiety in older adults, including older Black adults. So that explains some of the variability that we see in the reported data. Some reports are as high as 12.8% in terms of clinical depressive symptoms, and others are lower, the range is typically 5% to 10%. Okay, next slide, please. Thank you. So I've talked about some of this, and it's really important. I would strongly encourage all of you to not necessarily use the label depression or anxiety, but just assess people on the symptomatology. That, you know, you can ask the questions without necessarily starting with what the label is. And often amongst older Blacks, you may see some somatization. So they may not walk into your office and say, I feel depressed or anxious, but they may have a backache or other types of things that comes up in other minority populations also. But just being mindful of that, their sleep may be off, right? All those may absolutely be signs of depression, but they're not going to say, I feel sad or blue. So kind of going through the symptoms or asking more questions when they talk about some of their physical symptoms to really determine, is it a physical health issue, or is this is the way that they know how to express their mental health concerns. Agitation and anger is also something to really pay attention to, particularly with middle-aged and older Black women. So again, a lot of the physical health symptoms that people are talking about really could be their way of expressing their mental health symptoms. By just asking questions, you can kind of sort out which it is, and then that'll help you figure out how do you proceed down a mental health route, or if you're making a referral to a physician. Next slide, please. Okay. So I mentioned loneliness earlier. When we have older adults, older Black adults who feel isolated or feel lonely, you may see a higher rate of depression amongst that population. Being communal is a huge part for the Black American experience, the Black older adult experience. So kind of being mindful of that and definitely checking in if they're isolated, if they're lonely, how much they're engaging with others, and getting them connected to a senior center. Senior centers can be your best friends, right? Again, those community partnerships. So getting them connected may be all that needs to happen to start to see lower rates of depression. So sometimes you're like, oh no, they're depressed and anxious. Either we're looking for some medication or we immediately go to some detailed way of coping that may not be necessary. What they may need, if they're lonely, if that's part of what's coming up, is making them depressed, just to connect them with some community resources and or people. So the university, let's see, I'm participating in the grant that's called Resource Centers for Minority Aging Research. University of Michigan has one of those as well. But what they did during COVID, which I think is so fabulous, and I wish frankly it had been my idea, they had a lot of students who didn't have a whole lot to do at the time. They had students call older adults, and they talk about how great that was. So kind of creating phone trees or just kind of connecting people with people can be incredibly helpful. It doesn't take a whole lot of time or resources on our part, but it can make a huge difference in rates of depression and sometimes anxiety that we see. Something I did not talk about earlier, if we have older adults, particularly older men, who did serve in our wars and our conflicts, they may be experiencing PTSD, and asking them about those symptoms. Those labels aren't as difficult for older Blacks to hear as depression or anxiety or some of those other things, but still asking about the symptoms can be really, really important to try to figure out what's going on. You will often hear, if you talk to enough African-American families or Black families, they'll talk about the person who was different. They were just a little different. When I hear terms like different, unique, they say to themselves a lot, I then start to ask more questions. So you might see that could be the person in the family, like the older adult is now managing someone who has PTSD that was never diagnosed, it's gone untreated, and that impacts them as well. Does that make sense? So they're trying to manage this person who has some mental health needs that need to be addressed. You often find this is happening to older adults across the country. If they had children who had health issues, they managed them. They didn't want their other children to have to participate, but as they age, it's becoming a really, really big issue. That is true for older Black families as well. So often you have older Black family members who help the person who had mental health issues or disabilities. As they age, they've never asked for help, or at least not a lot of help, and they don't know how to do that now. So again, letting people tell you their story, understanding if they're providing care for someone and what their care looks like can be really important to helping figure out how to help them with their rates of depression. Okay, next slide, please. In terms of anxiety, so among African Americans with a 12-month major depressive disorder, 44.9% had a lifetime anxiety disorder. So we know anxiety and depression can go together. So it's really, really important to pay attention to that. And what I also want to point out is 25.5% reported lifetime suicidal ideation. So suicidal ideation is a really big concern when we're looking at younger African Americans or Blacks. It hasn't come up as much in the older African American Black population, in part because their coping skills are perceived as really great, and often they are. But I want to put a pin in that for a second. What we see, older Black women have the highest rates of obesity than any other group, if you can, if we're comparing race and gender. So there's a growing body of literature that's talking about some of those rates of obesity are related to maybe depression and anxiety. So it's really important to pay attention to food intake and how people are coping when they're feeling distressed. Okay. Again, you'll have access to my slides. There's some things on my slides that I'm not saying, but you'll have the slides. I want to make sure I cover some of the important highlights. Next slide, please. Okay. We know COVID was really important for older adults. I've tried to talk about COVID throughout my comments just to make sure if I didn't get to it, you would have that information. But we know COVID disproportionately affected older adults, but also within that, it affected older Black adults. A lot of them lost someone to COVID, family member, a friend, a relative, and that's just important to keep in mind. Next slide. Okay, the last bullet point on this slide is really important. You compound that with systemic racism. So CDC cited poor living conditions, occupational hazards, and negative health circumstances as key factors influencing COVID-related mortality. So sometimes people don't want to see us or talk to a mental health professional because of the stigma, particularly older Black adults. Ways, again, we can deal with some of that stigma is talking about symptoms, not terms, or not our labels that we would use, and really allowing people to tell their stories. Those stories often include racism, and sometimes, or racism, individual racism or systemic racism, institutional racism. Sometimes we're uncomfortable as providers talking about those things. I would strongly encourage you. It's just like hearing about something else. If it were a physical health issue, I'm not a cardiologist, but I can listen to my patients talk to me about their heart issues. The same thing, we have to allow people to tell their stories, because for this current group, part of their story could be about racism, and just allowing them to tell their story can really help us as we figure out how to treat them. Next slide. Okay. If you remember when I talked about the history, a lot of Blacks served in the war, a lot of Black males, and they came back from that service and then were treated poorly. So it's really hard for them to now want to engage. They were treated poorly in terms of health and other things too. So it's really hard for them to want to engage with the health community. The Tuskegee study, I live in Alabama, so the Tuskegee syphilis study is a big deal. And some people argue that it's related to some vaccine hesitancy for the larger Black population here. So being mindful of those things can be really, really important. But it has created a mistrust of health professionals. So just kind of, again, allowing people to tell you their story, I think, can really help them to develop trust in you. But just saying I'm trustworthy is not the solution. Letting people be their own experts, letting people tell you their story. If you feel comfortable, you can just ask directly if racism or sexism, racism in particular, has been problematic for them. Some will say yes, probably many, and some will not. But it's just, again, letting people tell their own story can be really helpful. And I think I have one more slide. Or maybe two. Okay. If you don't mind going to just my next slide, I've kind of covered this by talking. There we go. So older Blacks are not a monolithic population. They cover many communities, Jamaican, Haitians, and then those who are kind of from Africa, who are US born, and also other populations, other Caribbean populations and other populations. Assessment of depression, anxiety, and cognitive impairment are complex. Pay attention to somatic complaints, and thinking about food as a coping mechanism, and assessing family functioning is really, really, really important. And providing information about formal mental health services that are non-traditional, going to the senior center, or those other type of things can be really important also. And then the next slide. Okay, and then understanding and acknowledging kind of past and current racism, if that's important, that can really help you think through your diagnosis and your treatment. And then being mindful of triggers. So we talked about all those current events, like how is that impacting them and how do they think about all that stuff? So I hope my talk on some level was helpful. If you have questions, that'd be great. I'm sorry, I covered a lot of information, but really passionate about this and had a lot to cover. But thank you, and you will have my slides, and you can reach out to me. I'll make sure you have my email address if you have additional questions. Okay.
Thank you so much, Dr. Crowther. Really appreciate that. We are at time. I don't know if anybody has any questions, but what we can do, just send me an email and I can forward that to Dr. Crowther. Thank you so much for your time.
Thank you, and thank you all.
Great. Thank you. We have a lot of comments thanking you for the presentation.
Oh, thanks. All right.
All right,
Thank you.
bye-bye.
Bye-bye.